Even in the back, when you do this, keep your hands on the apices and the thumbs close to each other in the midline and ask the patient to take deep breaths in and out. Having tested the symmetry of palpation, then you move on to testing the vocal perimeters. The vocal perimeters is we use the phenomena of the sounds that are conducted through the lung tissue pleura to the chest wall when the patient makes any sound, preferably a low frequency sound like 99 or anuname. So you use your ulnar side of the hand and you keep the ulnar side on the rib spaces and not on the ribs. It's not important to check in every rib space. You can test that in different zones, and as you move your hand low down in the chest, remember to move your hand away from the midline, because as you know, ribs, when they come close to the sternum, the lower ribs are crowded to each other, therefore there is hardly any space between the ribs. So when you go down, you keep your hand in the rib spaces and move it away from the midline. Anuname කියලා කියන්නේ?
Anuname.
ආයිසරය?
Anuname.
ආයිසරය?
Anuname.
ආයිසරය?
Anuname.
Test the corresponding sides. And also, don't forget that there is a lateral side to the chest as well. So remember to ask the patient to keep their hands above the head, and to test the axillae and the lateral part of the thorax as well. Okay. Now I think at this point I should ask you to stop the tape and think of the conditions where the vocal perimeters is increased and the vocal perimeters is decreased. Can you make a list? And can you explain why in each of these conditions the vocal perimeters is increased or decreased? The third step in the examination of the neck and the thorax is the percussion. But before we proceed to percussion, let's take a minute to think about the answers to the questions I posed in the previous section. We talked about the vocal perimeters. The vocal perimeters is increased in case of consolidation, fibrosis, and is reduced in cases where the visceral pleura is separated or is separated away from the chest wall, such as pneumothorax and the pleural effusion. Let's look at the percussion. When you percuss, the technique is very important. Remember, all the movements from the percussion should occur at the wrist joint. The striking finger, this finger in this case, should hit the other finger at right angles. And only one finger should be touching the chest. These two fingers should be away from the chest wall, otherwise it damps the noise. The striking finger should be lifted off soon after it strikes. The percussion, also like in the vocal perimeters, you should test in each the rib spaces, the corresponding levels, and as you go down, you move the finger away from the chest wall. And you start percussion by percussing the apices. Here you can percuss the clavicles and then go down the chest wall with your fingers. Don't forget to percuss the axillae and the lateral part of the chest and also the back. Now, can you say what conditions the percussion note is increased? Well, remember that there are certain areas where the percussion note is dull. For example, in the cardiac dullness and the liver dullness. And obliteration of these areas, obliteration of the normal dull percussion is also important, and it's seen in cases where there's hyperinflation of the chest as well as in pneumothorax. So every time you percuss, you ask the question yourself, is the percussion normally resonant or is it hyperresonant in case of pneumothorax or in hyperinflated chest or in emphysematous bully, or the percussion note is dull like in fibrosis, cavity or the consolidation. Percussion note is stony dull in case of a pleural effusion. I suggest now you stop the tape now and try to think how you can differentiate consolidation from the cavity or from fibrosis clinically. Can you differentiate consolidation from a pleural effusion? You stop the tape and discuss among yourselves. The auscultation is the most difficult part to demonstrate in this presentation. When we auscultate for lung sounds, we use the bell of the stethoscope. It's advisable to use the bell because the rubbing of the diaphragm on chest wall hair can produce sounds very similar to crepitations. When you auscultate, there are four aspects you should pay attention to: intensity or the loudness of the breath sounds, which reflects the air entry, the character of the sounds, whether it's vesicular or bronchial, whether there are any added sounds such as crepitations or rhonchi, and lastly, the vocal resonance. Intensity of the breath sounds are reduced diffusely in conditions such as severe bronchospasm, but localized reduction of the breath sounds are heard in case of pneumothorax or pleural effusion. In case of the latter, the large pleural effusion, breath sounds may be totally absent. When you listen for the character of the breath sounds, you should learn to forget the lung sounds, forget the heart sounds, and then listen, paying attention to the lung sounds alone. Vesicular sounds, vesicular breath sounds are softer with a longer inspiration without a gap between the inspiration and the expiration. In contrast, bronchial breathing, bronchial breath sounds are much harsher, and they sound somewhat like this. Usually there is a gap between the inspiration and the expiration as well. There are different types of bronchial breathing. One of bronchial breath sounds called amphoric breathing is thought to be heard over the cavities. Bronchial breath sounds, bronchial breathing is characteristically heard over consolidations, fibrosis, and over cavity. Even in lung collapse, if the main bronchus is patent, you can hear bronchial breathing. Coming to the added sounds, there are two main types of added sounds, crepitations and rhonchi. In case of crepitation, there are fine crepitations and coarse crepitations. The fine crepitations are heard in case of pulmonary edema, fibrosing alveolitis, and in very early stages of pneumonia. Coarse crepitations are characteristically heard in bronchiectasis, lung abscess, and in pneumonia during the resolving phase. Pleural rub can be mistaken for crepitations unless you are careful. Pleural rubs are they sound much closer to the stethoscope, and it can be changed in case of when the stethoscope is pressed over the chest wall, they might become louder. Rhonchi, as you know, indicate the narrowing of the bronchi and the bronchospasm. Testing for vocal resonance helps you to reinforce the information you obtained when you tested the vocal parameters. Vocal resonance is increased in the conditions where the vocal parameters is increased and is reduced whenever the vocal parameters is reduced, but generally speaking is much more sensitive test than testing for vocal resonance. 99 කියලා කියන්න බලන්න.
99.
දැන් මම ස්ටෙප් එක තියෙනකොට ඔය 99 කියලා කියන්නේ. When you test for vocal resonance, you should get the patient to say something in very deep voice like 99 or 99. 99.
99.
I can.
99.
I can.
99.
I can.
99.
I can.
99.
Vocal resonance is increased characteristically over consolidation or cavity or fibrosis. Whispering pectoralogy is also something related to the vocal resonance, but here the difference is you get the patient to produce a very high frequency sound. රහසින් 1 2 කියලා කියන්නේ 1 2 Usually when you listen with the stethoscope, you cannot hear the words clearly. But in case of, if the whispering pectoralogy is present, you will be able to hear these words very clearly when the stethoscope is placed over the chest wall. Whispering pectoralogy is increased or is present whenever there is bronchial breathing. So it's a useful physical sign to confirm the presence of bronchial breathing. What I hope to achieve in this tape is to help you in developing the skills of examining the respiratory system. There's one way, only one way of mastering this skill. That is by repeating this drill over and over again on normal individuals as well as on your patients. Be grateful to your patients for allowing you to learn from them. Be gentle. Perfect your skill. You owe it to your patients. Thank you.